Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we have Professor Rui Rubirio, who is well-known bariatric surgeon at the globe. No doubt, Professor role for promotion of metabolic surgery, bariatric surgery, education, sharing knowledge, always dominant at the globe. In every society, you can see Professor is live with us, and really it's appreciable, no doubt. And always we see his role, especially in different international societies, and he's one of them who guide us and also give us guidelines. And definitely nowadays, you know better than me, ASMBS, as well as if so, their guidelines for metabolic surgery, especially in low BMI. And now we interview series is about metabolic surgery in low BMI diabetic patients that we have started with Professor Alper Chilik. And now we continue, and many big names like Surendra Ogale, Tarek Mehdi, Antonio Torres, and many, many. And now this will be our second last with Professor Rui Rubirio. And our last one will be with Professor Sergio Santoros. So, sir, so much thanks for accepting. And I know you're so much busy. So much thanks, sir. Please, sir, over to you.
Okay. Hello, everybody. Hello, dear colleagues. It's a pleasure to be here. I'm very honored for being here again, and I hope to have a good discussion with Imran, and for sure it will be very interesting. So sorry because I've been a little bit delayed, but I've been finished robotic sleeve, and that's because I was in the late hour. But anyway, it will be a pleasure. Indeed, metabolic surgery is our main activity since many years ago. Although we work in a private hospital, not a large volume of patients, but they are private, and at least we have a very good team, and we have a good chance to follow the patients very, very well, and the outcomes are very interesting, and they are always trying also to search for new techniques, for novel solutions for the problems of our patients. Our criteria, our policies to perform different operations, different techniques, according to the profile of each patient. For that, we make a study with all the complete team, as usually is recommended, and also with examinations. Sorry. So, what can I say since the beginning? My mainstream operation is still the OHGB that I embraced in 2010 when I came from Rouen gastric bypass to OHGB, because mainly at that time of hypoglycemia issues. I had at that time different patients with hypoglycemia, and that is really a difficult situation to solve with surgery or with medicines. And because of that, I changed to OHGB mainly. Also, weight regain was disturbing my activity. I had a lot of patients with weight regain, and because of that also I need to change. Well, 12 years ago, I'm comfortable with the OHGB, but facing the new techniques that we have in the international panorama, I decided mostly to embrace and to begin to practice the transit bipartition concept, Sergio Santoro. I began 7 years ago, slowly, because this is not a recommended, or I would say a recognized operation in Portugal. We have some guidelines from the government, some laws, and you need to respect it a bit. But in the last years, I've been performing it in the context of trial, a randomized trial, prospective, approved by an ethical committee, and that's okay. In that condition, there is no problem. So I have not a lot of patients nowadays of transit bipartition, about 100. But I have a good idea of the power of the operations, and we can discuss it later. Also, I'm doing some SADS. It is also a very good operation, of course, but indeed, the concept of transit bipartition, in my view, has the advantage of being, first of all, with no exclusion, bowel exclusion or stomach exclusion. That's very important, and may be reflected, or may reflect a lower incidence of nutritional issues in the future for the patient. This is very important, mostly because we know that the dropout rate is very high in every country and also here between us, even if we have a very good follow-up and the team that is searching the patients that are not coming to us. And we are also operating people from other countries, from Africa, for instance, that from our former ex-colonies, and they come up to us for operation, then they go to the places. And of course, it's not easy for them to do the follow-up, even with the video appointments, everything. But we need to care about that nutritional aspect. And the transit by partition is really a good option because of that. The second aspect of this concept that I appreciate a lot is the fact that we can have access to the biliopancreatic tree and to the biliopancreatic pathology by endoscopy that sometimes is disturbing in the patients with gastric bypass, whatever kind it is. And another advantage is a surgery that in case of some problems, and probably there are some cases with problems also, mostly even if it's a low percentage of people with a more sensible bowel that they have more bowel movements a day, in those cases we can easily come back to a sleeve, cutting the anastomosis between the stomach and the ileum. Of course, I'm I'm talking about the one anastomosis by partition, which is my favorite. And the situation there is more or less the same as the OAGB facing Roux-en-Y. Or I would say OAGB and diverted OAGB, the operation that I promoted a bit since 2013. And my policy is I go for OAGB if there are no problems of reflux, big hernias, esophagitis more than grade B, previous bands, previous sleeves. I prefer to do it in a Roux-en-Y configuration in order to protect patients from the reflux issues. And here with bipartition, it is the same. If I want to perform a bipartition, I would say that I go usually for one anastomosis, but if the patient has a reflux, an esophagitis, the same criteria, I go for a classical bipartition. And I suppose that this is a good kickoff for the discussion.
Sir, so much thanks really, and definitely we will talk about especially bipartition, your experience, and also about diverted OAGB. Definitely,
OAGB.
I have many questions about this. So now because we have divided these question in three session. In first part, we will talk about pre-op or patient selection, and then we will talk about some technical points of also bipartition as well as your technique, that is diverted OAGB. And then in third part, we will talk about your results. So now patient selection, because our main debate is about metabolic surgery in low BMI diabetic patients. How you select your patients and which BMI you define this is low BMI. Are you do any lab test? Which lab tests are compulsory to do before going to do surgery?
Well, for patients with low BMI, I would say between 30 and 35, mostly. I've been for years operating those patients. And which patients do need? The ones that have metabolic syndrome or its components, of course, an important diabetes, important dyslipidemia, invalidating sleep apnea, a dangerous steatosis with hepatic function disturbing. In those cases, we need, suppose that independently of the BMI, this is very well said everywhere, but we need to understand that the BMI is not the main issue in many of our patients. It's the diseases, the more important issue. So, and in those patients, if the associated diseases are very important, or even other situations like people with osteoarthritis of the lumbar column, for instance, they are with the problems about motility. That can be a good reason for to lose weight and improve the quality of life, or even recover their motility, for instance. And in those cases, of course, I do prefer techniques that have the metabolic power of controlling better the operation. And usually they are not restrictive, of course. We go for techniques like OAGB. It's still our first option, as I said. And OAGB has the advantage of being used in different kinds of patients. As you know, we can use OAGB for super obese patients with good outcomes. And for a patient with an important diabetes, with 8 years diabetes under insulin and a 32 BMI, we can use it also. Of course, we need to tailor the OAGB to those patients. And I learned with Professor Manuel Garcia Caballero from Malaga many years ago. He was a very important professor about diabetic surgery. He wrote the first book, which is called exactly Diabetes. And I have some samples with me yet. And what was he doing with OAGB? He was selling the pouch size and the biliopancreatic limb. Of course, he had a rule for that, but if the patient was between 30 and 35, he was doing a somehow larger pouch, not so narrow, and he was using biliopancreatic limbs below 150, for instance. And I've learned from him that kind of approach, and it works because those patients are not losing so much weight, sometimes with biliopancreatic limbs of 1 meter, 120, and that's not so aggressive operation. Of course, in those situations, it's not necessary to measure all the bowel as we do usually, but even if you can do it easily, it's better in order to not having any kind of risk. But in Portugal, the average bowel is 6.5 meters, so it's not a big issue to remove 1 meter for the biliopancreatic. And it works for the diabetes control. It can work for the dyslipidemia also, and for other situations. But in the last years, and mostly since I told you before 6 years ago, when I tried the first OATBs, I found that this is something that I'm not able to prove it, but that the anti-diabetic effect of the transit bipartition concept is stronger than the OAGB. And nowadays, with this class of patients, low BMI patients, I prefer with diabetes or dyslipidemia, I prefer to go for the 1,000 transit bipartition. With the same concepts, of course, we need to tailor a little bit, mainly the ileal loop or the common loop, doing it 300 instead of 250 or even 350 sometimes.
Sir,
And I have
excellent.
some amazing outcomes about diabetes.
Yeah. Sir, excellent. Sir, one thing that also we must be careful, especially in female patients or women who are after menopause, and also this is my question, and also symptomatic osteoporosis. This is confirmed osteoporosis. Patient is suffering with osteoporosis post menopause, so there is more chance of so definite aggression of this osteoporosis. As you recommend, because patient is suffering with vitamin D deficiency, calcium deficiency maybe, or that will be reactive. We can see high level PTH in these cases. So due
Yeah.
to reactive this hypocalcemia like this. So this is a confirmed osteoporosis. There is no doubt symptomatic till osteoporosis, and also patient is post menopause. Are you recommend any type of hypoabsorptive surgery in such a situation?
Not really, not really. In those cases, and that's a general rule also for OHB, in older patients, we need to be more economic. And but usually I don't perform OHBs above 60 years old. If I find a patient between 50 or after postmenopausal and with an important osteoporosis symptomatic, of course, I won't go for malabsorptive. I wouldn't say malabsorptive. With for an ileal operation with the risk of malabsorption, this better said, and I would go for a sleeve, which is not compromise so much the absorption, of course.
Yeah. Sir,
That's
just
one of my
imagine a patient.
indications for sleep.
Yeah, yeah, a patient, stable patient, 50, 45 years old, diabetic patient with BMI 33. There is no GERD, no such a complication. BMI is 33, but uncontrolled diabetes. Patient is young patient, no issue. So, which surgery you prefer in this situation?
In those situations, nowadays I'm very divided between OAGB and OATB, and I'm really doing a prospective trial comparing those two situations, and I'm not able to decide easily for one or the other. If the patient is more metabolic, diabetic, dyslipidemic, maybe with an important sleep apnea, probably I go for the more metabolic, which is OATB in my view. Even of course not, because OAGB can be more or less metabolic, but for regular OAGB, I suppose that the outcomes will be better. But if the patient is well, with bigger BMI, or the patient is very sometimes very compulsive and not compliant with the team counseling, in those cases maybe I go for OAGB. But I'm not sure about the difference of the outcomes. The only thing I suspect, but I don't have the data yet, we are running the trial, is that OATB is better for diabetes control. But in those situations, those two operations are the preferred ones.
Sir, with such a BMI, when BMI is 33, so what will be your BP limb if you're doing OAGB?
33, 1 meter, 1 to 120,
One
OAGB.
120 is sufficient for such a,
Yeah,
when your target is just metabolic or so this resolve.
metabolic, yes. Yeah.
Yeah,
And those patients usually don't have diarrhea, they have one bowel movement a day, or even one each 2 days with 1 meter, if they eat properly. Of course, nutrition is a very important aspect of our activity, because it's completely different, the reality, I suppose, for instance, in India or in Portugal or in Spain, because the food, our nutrition is completely different. We eat a lot of proteins, uh, and so it's more safe to do longer video pancreatic limbs in
yeah,
that point of view.
agree, sir. Absolutely agree. Sir,
Completely.
now have you any presentation you want to share?
Oh, I didn't think about that, but
No issue, no issue. We will.
but I can if I had one that, but he's not prepared. I would
No, no
spend
problem.
time
Sir. Yeah, yeah, no issue,
searching
no
for it.
issue. So regarding this transit bipartition, so are you prefer that loop in like SASI or no? You prefer like proper that transit bipartition like Ruan Y?
Honestly, I prefer the when anesthesiosis concept in general, in a general view. Uh, so I'm talking about OAGB for the bypasses, OATB for the transbipartition, SADS for the duodenal switch concept. Okay, and why? Mostly because I suppose that, and for sure, Santoro, Sergio will talk about that. The absence of an alimentary limb can have some advantages for the patients. First of all, um, we see that we have a longer biliopancreatic limb usually, and the long biliopancreatic limb is very important because we know nowadays that biliopancreatic limb is able to make the absorption of bile acids in a big amount. That's very well proven by different Japanese works in rats. Also, there is one work from Adriana Mika from Poland, I suppose, showing that in humans. So, and that's very important. So, if you have an alimentary limb, also the transit will be slower in that area, and that loop will suffer an important hypertrophy, and that hypertrophy uh, will have a consumption of glycosis, as you know, and that may have a role in the development of hypoglycemia. Mainly, I'm talking about the Roux-en-Y gastric bypass, of course, and that's why, because I told you I changed from Roux-en-Y for OAGB because of hypoglycemia. I had a lot of patients with that hypoglycemia. And nowadays, with the OAGB, I have no one important patient with hypoglycemia. But In the diverted OAGB, I have some patients with hypoglycemia because there is an alimentary limit, and maybe the consumption of a glycosis uh, since from the blood, not from the lumen, because that is not absorbed because there is no sodium usually. It will be important. Uh, and other issues is about internal hernia, because we know that usually the one osmosis techniques, they have much less internal hernia problems. And internal hernias is, well, something that we need to consider also. The rate is not so low. Sometimes I have seen already, even in a small country like Portugal, dramatic cases of bowel necrosis and the short bowel, and death also because of internal hernias. And with OGB, with OATB, and SADS, the rate is very, very low, much time lower than in the Roux-en-Y configuration. That's another advantage.
Sir,
And of course,
yeah.
just again, sorry, reversibility. Or say, it means if you want to have an exit strategy with one anastomosis, whatever is the operation, it will be easier to go back if there is a problem with the patient. Sometimes patients have cancers after the bariatric surgery, and they want to revert, and we need to preserve that possibility and to make it easy.
Sir, when you prefer SADS, which patient is good candidate for SADS?
For the worst patients. If I have a guy with 250 kilos, uh, well, without compliance to the nutritional teaching, with the psychological report saying that he's not able to assure a proper follow-up and so on. A proper follow-up, I mean, sorry, um, to take properly the vitamins, for instance, I'd go for SADS. What do I don't like, or what I don't, why do I not, I don't like in SADS? Exactly there is a long biliopancreatic limb with the excluded segment. This is an excluded segment. It's good for bile absorption, but I don't have access uh, well, sorry, this is not true. I'm confused. We don't have the reversibility that I talked before, because to reverse SADS is very difficult. I've seen it from André Sanchez Pernaute, and it's the difficult operation to make a duodenal anastomosis to reconstruct the bowel transit.
Sir, another thing. So, if in a smoker overall, so definite in your practice also, this is difficult to select a heavy smoker. If patient is a heavy smoker, and also you are going to do any type of metabolic surgery, so routinely, we never prefer to do any type of gastric bypass in such a case due to high rate of marginal ulcer in these patients. So, what is your opinion about SADS? Because when we do SADS, there is duodenal ilear or
Yeah,
duodenal jejunal anastomosis.
yeah,
What's your opinion? Can we do in these cases?
sure. Yeah, because we know that in the duodenum there is a lot of portion of mucus that can protect the mucosa, and still the short segment of the duodenum can make some buffering of the acid, and also there is some protection because the emptying is very quickly. So the marginal ulcer is very, very, very rare in that situation. So it is one of the situations, but usually you are right. I don't perform bypasses or OATB in people that are smokers. They need to stop smoking 1 month before at least, and after that we can do an operation. Otherwise, I go for a sleeve, or and as an hypothesis in a big patient or in the condition that I said before, we can go for a SADS, of course.
Yeah, because sometimes, sir, we are facing a patient who are using chronic this NSAIDs due to osteoarthritis or any type of disease, and also they have past history of gastritis, and sometime we think, yes, if I will go for any type of gastric bypass, there is more chance of marginal ulcer. In such a
Yeah.
situation, definitely you prefer to go for Sadi S because at least more physiologic as compared to direct anastomosis of any type
Sure.
of small bowel with stomach. Sir, my question in Sadi S, one of my concern is access to duodenum. So in future, if patient need any type of access like there is CBD stone or
Yeah.
something like this, have you any experience of so you did SADS or your any colleague and now patient is suffering with the CBD stone. So have you any experience
Mm,
of such a situation?
no, well, let's say our policy about stones is to, if the patient has stones, we remove the gallbladder in the operation, or if it is sometimes it's difficult because heavy livers or because of a long operative time, and if it is not easy or quickly to remove the gallbladder in the operation, we defer for 3 or 4 or 40 kilos later or 30 kilos later, as I used to say to the patient. When you lose 30 kilos, we will remove your gallbladder, and we take note of those patients. We don't want to lose them because we don't want them to be writing with gallstones. But some people's we are going to miss them, of course. And I only remember the problem with the patient with the urinary gastric bypass with a cholelithiasis, with an obstruction, and I had to operate by open surgery because we are not able to perform really the ERCP. So it was only one case. With SADS, we don't have a lot of cases, and I've never seen problems. I never have cases with that kind of situations, but it will be a problem for sure.
But overall, sir, in Roanwai or in case of OAGB, because we have remnant stomach, assisted laparoscopy, we can put the trocar in remnant and then our endoscopist will have access to duodenum by that way. But especially SADI is much difficult. Then definite,
Sure.
you can go with laparoscopy, you can explore
It's
CBD.
impossible. It's impossible. Yeah,
Yeah,
I would say.
it's much.
And you cannot do the retracted double balloon endoscopy because it's too long, or it will be
Longer,
very,
yeah.
very difficult. Sure. But well, I have done that technique of the observation, the duodenum through the remnant, but not for gallbladder or for colitis, but for a duodenal tumor that I had in a patient, and I had to perform that. And it was fortunately a benign tumor of the duodenum. It was a big one, but no problem. But we have performed that, and we know some colleagues that have that it in my group, hospital group, because I work in 2 different hospitals with 2 different teams, and they have done it in one of them. But okay, the best policy is prevention. And by the way, I would say that we give ursodesoxycholic acid for all the patients in the in the postoperative period, for depending of the weight of the patient, the BMI, for at least 3 months in order to decrease the rate of cholelithiasis. Sure.
Yeah, definite, sir. Because again,
Coming back a little bit for the marginal ulcer, I need to say that the rate of marginal ulcer here in my country, in my hands, it's the same between Roux-en-Y gastric bypass and OHB, 2%. Okay, and it's quite low. I don't know why. What I know is that in the Central and Northern Europe, it's higher, the rate, but again, maybe something because of food. We have somehow some Mediterranean diet also. Maybe because of the wine, I don't know, but some genetic non-predisposition. But we have a low rate of ulcers, and they are usually easy to to deal with. I can say that in 22 years of bariatric surgery, I've operated only 2 patients, one because of perforation in one diverted OAGB perforation, but sealed in the anterior abdominal wall, and another one that was not really perforated, it was just almost perforated in OAGB. 2 cases in more than 3,500, okay, so it's very low perforation. But also we have 2%, and they are easy to solve. Of course, we need to say also that I put all my patients with after the operation with 1 year of PPIs. Okay, and that's, I suppose it's important, mostly in males, because when I was not doing that strategy, I had 3 cases of hemorrhage in people, in men, in guys that were drinking alcohol. That's another fact that we didn't consider. If the patient is alcoholic or he wants to keep drinking alcohol, don't go for a gastroenterostomy easily. May be dangerous.
Sir, one of the thing that you know also better than me. So if we compare Roux-en-Y with the OAGB, the marginal ulcer in Roux-en-Y gastric bypass comparatively more as compared to OAGB. Till we can see the pouch size of Roux-en-Y is smaller than OAGB, but
Mhm.
maybe due to buffering effect of bile, so we will
Yeah.
see less percentage of marginal ulcer in OAG. What is my question regarding this diverting OAGB? So we have a longer and larger gastric pouch. So how many cases till this time? Have you any data you did diverted OAGB? And what was the percentage of marginal ulcers if you compare with simple OAGB, that standard OAGB?
Okay, I agree completely with you because marginal ulcer is mainly an issue of acid, not of bile. Because all the marginal ulcers they are born in the enteric slope of the anastomosis. So, and we know that bowel is used to have bile, so that should not be the problem. It's acid, maybe acid mixed with the bile, but acid is the main problem. And theoretically, a longer pouch will have an higher chance of marginal ulcer because there is more acid, of course. I do agree that, and in my data, I can see that also. We have a little bit more cases of marginal ulcer in the diverted OAGB. And that's one of the reasons also that we are doing less cases of the diverted OAGB nowadays, giving preference to the bipartition also in that point of view.
Yeah, definitely. And also,
Yeah.
sir, have you any experience of internal hernia in your diverted OAGB or no? You always you close and that you were lucky and your patient were lucky. You have not
Yeah,
such a situation.
I have some experience as much as with my older ruin wives. I remember one cousin of mine that had one. She was in the emergency department. She called me and I went up to there, and they were already charging the lady home, and I went to take a look on the CT scan, and there was an internal, and I said, no, she's not coming home, she's going to the OR. But that wasn't one mine. But I had at least 3 cases of internal hernia. Um, so it's not a big number also, but I have a disastrous case, I would say 2 years ago. It was a patient with a diverted OHB with 8 or 9 years. So it was a teacher. The man was very good weight, happy, but he developed, he came up one day with abdominal pain, and I went to the study, and I found one pancreatic cancer in the guy. So we went for the treatment with it was advanced. I made the stage. He went for the chemotherapy, and because of that, he has lost a lot of weight more. So he is very thin at that time. And in that time, he developed a terrible internal hernia. He went for one emergency department in another city, and the situation was not diagnosed, and he died there because of that.
Yeah.
And I talked with the patient. There was a complete hernia of all the bowel from the left to the right with necrosis.
Yeah. Sir, another thing, because now today we are talking about metabolic surgery in low BMI diabetic patient. So when patient consult to you for treatment, this is my just question. So what is the culture of in your city in Portugal? So patients now think about this. This is public awareness sufficient? Yes, I will go to the surgeon just for the treatment of diabetes, not for obesity. Now it's practical in society or not yet?
Not yet. Unfortunately, it's not a rule because I don't want to blame our colleagues, endocrinologists or the internal medicines or people that deal with diabetes because of that. But I try to advertise that kind of surgery. But some patients came, but not a lot, honestly. And of course, we have some cases, but there's not a big series of that.
Yeah. So then, if any case, so consult to you for just for diabetes. So are you going to do some test like C-peptide or some serum insulin or so to predict, yes, this is your C-peptide, your low BMI, and this will be percentage of success for remission of diabetes.
Well, I do like a lot the concept of the scores. So, of course, I do the measurement of the insulin, of the C-peptide, of the, sometimes I do, of course, the glycated hemoglobin. We need to also to look at that, the time of surgery, the sex. We know all the factors that we know if they are using insulin, how long they are using, more, how many different drugs they are taking for diabetes. All those issues are important in order to define what kind of surgery. But I like to use the score. Not only, of course, C-peptide is important in order to exclude the antibodies to the insulin and to the beta cells are important in order to um,
Rule out LADA.
to rule out LADA. That's it.
Yeah,
Yeah.
definitely. Because sometimes there is an autoimmune impact. And if we will go for surgery, this patient diabetes improvement will happen, but this will be not complete remission.
Yeah.
And when we will talk with the patient, yes, when we will do this surgery, you will lose your weight. Maybe your microvascular side effects will be, we can control and we can delay those microvascular side effect or complication, but this will be not complete remission.
Yeah, sure. Something that is different also is that in those patients we make a complete evaluation mainly of the ophthalmologic of the eye because of the retinopathy. That's important in order to evaluate the importance of the macrovascular disease.
Yeah.
And
Sir,
of course, renal function is also important.
yeah, nephropathy. Sir, is it routine to check up just because you highlighted? So before going to do surgery, patient is low, they are low BMI diabetic patients. Is it routine to refer the patient to rule out any type of retinopathy or nephropathy before going to do surgery?
Yes, it's a routine for myself. I do in all the patients that are not really bariatric to evaluate, to ask for an ophthalmologic evaluation and to know the degree of retinopathy. Because if the patient is has a more advanced diseases, we have first of all more risk for the operation.
Yeah.
And maybe we need a stronger operation in order to control better the evolution of the microvascular disease, whatever is in the kidney, in the heart, or in the brain.
Sir, you're definite because you are not only a surgeon, you are a scientist, and always we look toward like a researcher as well. Because personally, also, this is my opinion. Have you any data to follow your diabetic patients? You're only diabetic patients. Yes, you did these diabetic patients, and now you are following. And also because you are following their improvement of microvascular complication. Yes, this was the grade of nephropathy after 6 months like this, 1 year like this, retinopathy was like this, and now this. Have you any data for these patients?
No, honestly, I don't agree with you. I'm sorry. I'm not a scientist. I'm a surgeon mostly, and I work in in a clinical setup, not in an academic setup. So it's for me, it's not so easy to have some kind of clinical research with such a deepness. So I do some clinical research, but somehow superficial, you know. because we are not able to measure systematically for instance, the hormones that we'd like to, the the evolution uh, of the cardiac factors, for instance, the cardiac function or the kidney functions. Um, we are not able to do. I follow all my patients very carefully in the surgical point of view, but mostly for diabetic people, I like to send them for our endocrinologists from my team and the internists also. So, and they do that job for me. Not, I'm not doing that kind of research. I'm sorry.
Sir, excellent. Sir, regarding this OAGB and also bipartition, now you are doing OAGB more than 1 decade and as well as bipartition more than 7 years. At least you have some cases of bipartition. Are you aware about this bipartition? So you did surgery for your diabetic patients. Have you faced a relapse of or yeah, reoccurrence of diabetes in your cases?
Yes, I had some in OAGB, some cases because I'm doing it for a longer time. And I remember exactly a dozen of patients that I operated with low BMI and severe diabetes, and they have a kind of relapse, and they come back saying that were again taking insulin that were not there left before. But curiously, with OATB or transbipartisan, if you want, because there are some cases also with two anastomosis. I can't remember any of those cases. But that we are going to show with our now prospective trial that we want to run for 5 years. Um, Follow patients for 5 years, even more, to control to see the difference between the two operations. But as I told you, my sensation, but it's only an opinion, it's that OATB is more effective for diabetes.
Yeah, definitely. Sir, what is your opinion? Because this interview series, the main target is sharing knowledge by an expert and also their opinion, their experience. This is more important. Not we are talking about the data or something like this that is from IPSO or other organization, because this is very important. Just in my opinion, we are at least 5 year ahead to a book or text, because these things that we are hearing from your side, this is your personal experience. You're
Yeah,
facing, your patients are facing, and we are at least 5 year ahead to the book. These things will be maybe after 5 years, so we can see in books and research papers. So,
no,
but yeah, please, sir.
tell me.
Sir,
Okay, and you need to combine your data, your patients' information, evolution with the theory and the research work that they are doing all over the world, comparing new techniques and new mechanisms. Of course, I went for transbipartition because I have the sensation before in the beginning, or even for AGB, that the operations with longer biliopancreatic limbs add the more power, even for obesity, whatever, for obesity or for metabolic diseases purely. So they are more intense, I would say. So, and I suppose it's not only because the longer biliopancreatic limb, but also because the early ileal stimulation. And you know that is very important. And I'm very well related, as you know, with Brazilian surgeons, and they are very active, and they discuss a lot. And of course, we know that the different ileal mechanisms to control metabolic disease. So I'm not speaking only about GLP-1, but also about GLP-2, V2, GLP-2, also about FGF19 that Santor will talk to you. It's very important nowadays. Also because of the that is produced by the enterocyte itself, mostly because of the having together the bile and the undigested food into the ileum. That is the clue, that is the key to develop a good anti-diabetic effect. And the operations that can do better, and even in my concept, what I have said before in my practice, based not only in because I decided to do it, but theoretically, it will work. If this is true, it will work better in OATB than in OAGB. That's why I'm doing the comparison of that.
yeah, definitely, sir. That as you have highlighted, So the main concept in the treatment, surgical treatment of diabetes type 2 is so this undigested nutrient to terminal ileum. You can do sleep plus again you can do this loop that will be entro ileostomy or entro jejunostomy and then game up. So when food will go to undigested, this nutrient will go. So what's my questions are regarding these patients that were suffering with reoccurrence of diabetes after OAGB. So what is my question? What do you think about these patients? Why this occur? Maybe before going to do surgery, their beta cell reservoir was less and C-peptide was low, or no, they started to eat that sweets and I don't know, carbs and so maybe I don't know.
My idea is that diabetes is not only a question of insulin production, of the amount of insulin production or quantity. It's also an issue of insulinosensitivity and also dysfunction of the beta cell producing insulin. So, and this is a recurrent disease. I learned from many years ago from a German teacher, professor, that he was saying that if you would live 120 years, all of us would die with diabetes because the pancreas is not eternal. We can spend it a bit. So, and diabetes is a chronic evolutive disease. And what surgery is able to do through some mechanisms that we know is it can delay a little bit and it can pull down a little bit the process of development of diabetes. But with time, it will take its normal route and the insulin sensitivity will decrease again and the functionality of the beta cell will decrease again, and that's why we have some recidivism about diabetes. But not only. For instance, there are now very interesting works about the role of pancreatic enzymes in the control of diabetes, and there are some proofs that, well, some clues, some hints, and people are investigating that aspect. And at least for the control of hypoglycemia, it seems that taking secretin can help a bit, for instance.
Yeah, definitely, sir. Nowadays, so if we see the role of microbiota, and when we do any type of gastric bypass, so our especially biota, is aerobic, not anaerobic, because we have oxygen in small bowel, and the change of this microbiota, that is interesting. And as you have mentioned earlier, the role of bile. So when bile acids rise, and then those receptors and mitochondria and many things. So definitely in future, so we will see more and more information about our git, I think, gastrointestinal
Yeah,
tract,
yeah, yeah.
that still is hidden and we have no idea about this. As you have mentioned, Rubinio and Michel Garnier, they started in 2004, and that was the foregut and hindgut theory. And as you have mentioned, so when we will go for OAGV, then because we bypass that proximal part of small bowel, especially duodenum, and then when food will not pass from that area, suppression of some incretins that are anti-insulin, and also rise of and also inhibition of GIP and many things that already.
Yes.
Yeah.
And the consumption of glucose by the bowel itself, it's very interesting. By microbiotic is a wonderful world, in my view, uh, and microbiota is also very variable. We have some spots of how it is when we are going to study, but it's always different. Maybe our microbiota is different from the Monday from Friday because of the work, because of the stress. Everything is important. But what is more important in my view, and probably the main cause is that people that are obese, they change their food habit and they begin to eat better. And you know that microbiota, there is a trend for people to give probiotics to their patients. It seems not to be so valuable because the better way is to give prebiotics, fiber mainly, in order to provide the bacteria in the colon in the ileum with the proper fuel to produce the short chain uh, uh, short chain fats, okay? Mainly butyrate, which is the main one that can itself produced by the bacteria that eat the right food, fiber, and that can increase the power of the L cells producing GLP-1 and the other incretins. So it is a kind of redundant mechanism. People eat better, and of course, they will have more food in the bowel, more GLP-1, and a better microbiotic that will itself increase and make a more powerful incretinic effect.
Sir,
And we need to understand that we need to manage the food more than the giving bacteria to the bowel.
sir, that thing that this is, in my opinion, this is the beauty of this interview, and in my opinion, this is a new thing, new concept. So bariatric food,
Yeah.
so our metabolic food, I don't know, diabetic food, something like this. Is it possible to provide this concept, especially our industry, to provide such a food that will be available for our patients? So then it will be much easier to take. Yes, this is the packet, this is the food ready for you, and you can take this food. This just like, imagine, always we prefer to use some multivitamins and supplements for our patients. Personally, I never prefer protein shakes, but so okay. And bariatric fusions and many names so available in the market. So can we go ahead with the bariatric foods?
Sure, we should work on that because I stress a lot with my nutritionists. I have three nutritionists, and two of them they are PhD, and they are important about the study of the microbiota. They have experience about that, and I would say that we know which food is good for having a good microbiota. So mainly fiber, protein, not so different the concept of the surgeons, but and to avoid, of course, simple carbohydrates and fat. And if you do that, and to know which are the good patient, the good food, the good pieces of food that we can eat. For instance, potato is the main source of butyrate. It's a
Yeah,
rich in butyrate, so
butyric acid and then
we should recommend butyrate. We should recommend non-digestible fiber like the we can offer patients to eat potato and rice and what else pasta if it will be boiled, put in the refrigerator and eaten cool. So because it will be poor fiber. They are eating carbohydrates, but it will turn fiber in the end. So we need to teach that to the patient, and I do that a lot. I have a presentation in my computer, and in one of the first sessions, I show them. You see, these are the good food, and you can eat what potato. Yes, you can do it cold, not hot, not finished to
yeah.
boil.
So, like just as you have mentioned, so butyric role of butyric acid, especially in microbiota, is very important.
Yeah.
And also, yes, this is when patient will take more potato. So definite, we are feeding our beneficiary our good microbiota, and then definite the growth of microbiota and impact of microbiota, as you have mentioned. Definite, we will this will be fruitful, and we will take more better results as compared to if.
Sure. And we need to consider also that microbiota is not only important for the metabolic control, it's also important for the cardiac function, for the brain function, for the immunosystem function. So it implies advantages in all the systems of the bowel. So that's why it's so important to eat well. And that's why we need to teach people to eat well and not only to operate them because of them. If they are going to eat badly, they will come back for sure, at least a piece of steps.
Because sir, nowadays, so it has been proved that, so they check the feces of patients after bariatric surgery, and also before, are those who are not bariatric, they don't have this microbiota is different. So this there is no doubt, this
Yeah,
has been proved nowadays. And the
sure.
And in
And
future,
there are interesting cases. For instance, there is one bacteria that is Akkermansia. It's very, very important. And if we are able to improve the colon with the Akkermansia, the with food, with um, immunonutrition, I would say, we can have lots of advances for the patient. I was ready for a study. In that case, it was an international research together with Campinas University in Brazil, São Paulo, and we made a project to compare the microbiota of patients before and after bypass,
yeah,
and comparing the same thing between Roux-en-Y gastric bypass and OAGB, and simultaneously the situation in Brazil and in Portugal. So to see if for the same operation the outcomes will be different about microbiota. But it's a wonderful. We couldn't get approval and a sponsor for that sponsorship for that kind of study
study.
that was driven by a friend of mine, which is Dr. Daniela Magro in the Campinas University. But that's what I was telling you. It's not easy to
Definitely, it
make.
will be very interesting and fruitful for future, sir. Definitely, it will be very
Yeah,
effective.
I
Sir,
suppose.
really, so much thanks, sir. So I take your time, and it was really very, in my opinion, fruitful, and also a lot of knowledge, especially microbiota, role of microbiota. So now, sir, and now in 2022, Professor Rui Rubirio, who love his patients and definite patient love him. So in a low BMI, so again, I repeat my question. In low BMI, diabetic patient, there is no such a complicated patient is okay, patient is stable, but just uncontrolled diabetes, low BMI, which surgery you prefer?
Transit bipartition, I've told you before, and I keep the opinion. Transit bipartition, in my opinion, can be possibly, I can't swear, but I, I have the thinking that it can be mainly the main operation. And I can tell you why I think like this. Because I know most of the main, I know closely most of the main names of diabetes surgery. Auri de Paula, Ricardo Cohen, Surendra Ugale, Alpert Celik, all of them, mostly Alpert Celik and Surendra Ugale, they were performing the ileal interposition, as you know,
Yeah,
and they changed a bit for the concept of the transit bipartition. Why? Because, of course, the ileal interposition is a wonderful concept. It would be the perfect operation for the situation that you are describing, ileal interposition, because it's really metabolic, purely metabolic, and those patients won't lose a lot of weight. But the rate of complications and the difficulty of the operation is disturbing. And I don't want to have I suppose that in this kind of activity that we embrace, that we are not allowed to have a lot of complications because it will be bad for all, for the patient and for us and our name as a professional, as a class, because it is in the end, it is a benign disease. We are not allowed to have deaths and very severe complications, and that operation has severe complications. That's why some of our honored colleagues have changed a bit for transit bipartition, and I would say that I'm following these steps.
sir. Now at this stage, what is your main concern after transit bipartition?
In one anastomosis, my main concern is, as in OAGB, bile reflux to the esophagus. That cannot happen. That is really dangerous, okay? So that's my main concern. And a bit the problem of the marginal ulcer that can happen theoretically in the gastroileostomy, in OATP, one anastomosis, but by now, I had only one case with very superficial erosions in the nasal that were easily treatable. But I'm still feeling that it can happen in patients in the future, that those are the main issues. Some other colleagues of us, they are wondering about what is the effect of recirculating bile, the bile that goes to the bowel, comes back to the stomach and go to the bowel. Can this have some kind of problem? We don't know. We need to look at the patient in the future.
Sure, sir. Sir, for your message for our youngsters who are just now going to start metabolic surgery.
Well, my message will be a little bit like the one that Malfobi said in the last best in Tijuana, where I have been. So we have where we have run a long journey from since the beginning. We had a lot of concepts, and we are some kind of specialty. We have a concept, we have some consensus about some things, but please look at the past and take note of the problem. Learn with the past, and please respect what we have learned from the past. So be careful about the complications rate. Be careful about and take care about the multidisciplinary team and the good follow-up and the good preoperative study workup, and choose the best operation for each patient after the studying and knowing the patient very well. And in that way, we can have a good outcome in your practice. If you are going to perform the same operation for all the patients, if you are going to operate the patients and don't give a damn to the follow-up, and you leave the patients lost in the real world, that will be not good for you, and of course not for your patients.
Sir, so much thanks. And really, you are always sportive, really, always sportive and encouraging. In future also, we need your support. And this session was second last. My dear, so much thanks. This all sessions is due to your support. Until this time now in Dubai is 2 a.m.
Yeah.
Until this time, so I can see many of my colleagues from Middle East. They are live with us here at Facebook. And so much thanks. These are sessions are due to your
Okay.
support. And at 27th December, we will be with the Professor Sergio Santoro, who is a
Okay.
pioneer of metabolic surgery. And that will be our last session of metabolic surgery in low BMI diabetic patients. And in Jan 2023, maybe in mid or at the end of January, we will have a sum-up session of metabolic surgery in low BMI. And then we will continue our interview series with redo surgeries. And also, then you will see many stars and stars of bariatric surgery. And we will continue our interview series. So much thanks, sir, again. And really appreciable. And in future also, we need your support.
Okay, thank you so much. Greetings for all the colleagues, and thanks for having attention to my humble experience. Thank you so much for the chance to be with you today.
Great honor, sir. Great honor.
Bye-bye.
Much